Hello, good morning. Dr. Ishani, can you hear me?
Yes, ma'am. Good morning.
Good morning. Will more people be joining online or should we start?
Ma'am, I think we should wait for another 2-3 minutes and then we can start.
Okay, okay, sure.
So, should we begin?
Yeah,
Okay. Ma'am, since Dhyanisa will be joining us shortly, I think we should wait
okay,
for
okay,
5 minutes.
okay, fine, okay.
Room, and if your moderator would give permission.
Yeah, hello, Ishani.
Yes, ma'am.
Yeah, I think we can start now.
Yes, ma'am.
Okay, please start. We're starting the lecture. Thank you.
Good morning, everyone. This is a tutorial on Cariprazine, moderated by Dr. Sanjeevni. So, antipsychotic drugs are commonly prescribed for a variety of psychiatric conditions, in addition to individuals with schizophrenia, which was the original target patient population. They are also used for bipolar disorder, depression, anxiety, delirium, insomnia, agitation, and aggression in various patient types. Antipsychotic medications, particularly the atypical second generation antipsychotics, have come under scrutiny due to an increased risk of weight gain and metabolic adverse effects, such as glucose intolerance and lipid abnormalities. Now, Cariprazine received approval by the US FDA for the treatment of schizophrenia in September of 2015, for treatment of manic or mixed episodes associated with bipolar disorder in 2015, and for bipolar depression in 2019. The development arose from a systematic search for a compound with high selectivity for dopamine D3 receptors over D2 receptors. Cariprazine is a dopamine multifunctional agent acting as a partial agonist at dopamine and serotonin receptors. Let's talk about the mechanism of action. So, cariprazine acts as a partial agonist at D3, D2, wherein the clinical effects due to D3 receptors are improvement of positive, negative, and depressive symptoms, and procognitive effects. Due to D2 are improvement of positive symptoms. Due to the serotonin receptors, the improvement are mostly shown in negative and depressive symptoms. Due to 5-HT1A, improvement of negative and depressive symptoms. 5-HT2A lowers risk of EPS. 5-HT2B, 2C both show improvement of depressive symptoms. And again, 5-HT7 also shows improvement of depressive symptoms with procognitive effects. Now, cariprazine also has moderate affinity for H1 receptors, low affinity for alpha-1A adrenergic receptors. High affinity for alpha-1B receptor is linked to reduced EPS and akathisia. No appreciable affinity for cholinergic and muscarinic receptors has been seen. High affinity of cariprazine at D3 as well as actions at the serotonin and alpha-1B receptors differentiate it pharmacologically from the other antipsychotics. Let's talk about the binding profile of D3. Now, cariprazine acts as a partial agonist or antagonist, blocking the D3 receptors and inhibit the somatodendric activity. This in turn increases the dopamine release in prefrontal cortex. With increased dopamine, this increased dopamine functions to re-regulate the aberrant cortical activity and hence could theoretically result in improvement in the negative symptoms and cognitive impairment. Talking about the pharmacokinetics, the bioavailability is 52%. Emax is reached in 3 to 6 hours. The volume of distribution is 0.5 liters per kg. Plasma protein binding capacity is 91 to 97%. Metabolism is primarily by cytochrome P3A4 and to a lesser extent by cytochrome P2D6. The active metabolites are desmethylcariprazine and di-desmethylcariprazine. Excretion, 21% of the daily dose is found in urine. No dosage adjustment is required in patients with mild or moderate renal impairment if the creatinine clearance is more than or equal to 30 ml per minute and less than 89 ml per minute. Now, use in mild to moderate hepatic impairment must be cautious. The time to attain steady state is 1 to 2 weeks, and the T half is reached in 2 to 4 days. Now, talking again about the indications, use of cariprazine in bipolar disorder showed significant improvement in biomarker score in phase 2 and phase 3 trials, favorable outcomes in long-term study in patients with acute mania or mixed episode, and was seen as efficacious as both an antimanic and antidepressant therapy. Cariprazine in schizophrenia showed significant improvement versus placebo in positive, negative, cognitive, and mood symptoms, significant improvement in negative symptoms versus risperidone, improvement in overall disease severity, symptom intensity, and quality of life. This was more effective than placebo for relapse prevention as well. Henceforth, the guideline recommendations for this, Midlands and Lancashire Commissioning Support Unit UK 2019 recommended cariprazine as a second-line therapy in patients with predominantly negative symptoms of schizophrenia. American Psychiatric Association Practice Guideline of 2019 included it as a treatment option for schizophrenia. Then CANMED and International Society for Bipolar Disorders 2018 talked about this alone or in combination as one of the first line treatment for acute mania and second line treatment of bipolar depression. The adverse effects in a study done with a sample size of 402 patients, it was seen that the most common side effect was akathisia, seen in 32.6% patients, followed by headache, constipation, nausea, dyspepsia, toothache, tremors, insomnia, EPS in 6.7%. Restlessness, vomiting, sedation was seen in significantly lower amounts of about 5.7% of patients. Weight increase was also seen in less amount of patients, that was about 5.7%, and diarrhea was the least common side effect seen in about 5% of patients. Talking about the dosing, firstly, in schizophrenia, it ranges from 1.5 milligrams to 6 milligram given once daily. Starting dose is 1.5 milligram and can be increased to 3 milligrams on day 2. The dose adjustments should be made in 1.5 or 3 milligram increments, and the maximum recommended dose is 6 milligrams per day. Now, in manic or mixed episodes, it ranges from 3 milligram to 6 milligram once daily. Starting dose is again 1.5 milligram and can be increased to 3 milligrams on day 2. The dose adjustments to be made in 1.5 milligram or 3 milligram increments. And again, the maximum recommended dose is 6 milligrams per day. Talking about cariprazine's use in special populations, firstly, the safety and efficacy for pediatric use has not yet been established because the pediatric studies have not yet been conducted. In geriatric use, doses need to be started at lower end of the dosing range owing to renal, hepatic, and cardiac dysfunctions. In pregnancy and lactation, neonates exposed during the 3rd trimester of pregnancy are at risk for extrapyramidal and or withdrawal symptoms following the delivery. Lactation studies have not been done extensively to assess its presence in breast milk. Now, the contraindications and interactions. This is firstly contraindicated in patients with history of hypersensitivity reaction to cariprazine. The reactions may range from rash, pruritus to angioedema. If being given with a cytochrome P inhibitor, likely itraconazole or ketoconazole, this reduces the cariprazine. So if it is given with an inhibitor, we need to reduce the dose of cariprazine and give it. And if being given with an inducer, it is mostly not recommended. Inducers being rifampin and carbamazepine. In conclusion, it is known that cariprazine has a greater affinity for D3 compared to D2, resulting in improvement in cognition, mood, and negative symptoms. High affinity for serotonin, 5-HT1A and 5-HT2B receptors may contribute to antidepressant efficacy. Meta-analysis shows greater efficacy of cariprazine in treatment of negative symptoms. Its major metabolite di-desmethyl cariprazine has an extended half-life, thus providing protection against relapses when doses are occasionally missed. It also has a favorable safety profile, showed low tendency to cause sedation and drowsiness, and also has low risk of hyperprolactinemia. These are my references. Thank you. I'm open for discussion and questions. Sorry.
Thank you, Ishani, thank you, Dr. Ishani, for the presentation. I invite questions from the audience if anybody wants to ask anything.
Is there any relation to food intake? Availability is 50%.
Yes.
Does the food intake change with like the bioavailability change with how the drug is taken with food?
So only one correlation was seen with vitamin C. Apart from that, sir, I tried, it increases
should not be given in the pregnancy?
So we can give it with fruits that contain vitamin C, but not with tannins and coffee and tea and all. That reduces the bioavailability.
There is no such direction that you should give with food or
No, sir.
Any Indian studies?
I
I remember there was a trial, multi-center trial in India, after which they actually got approval from the rest. It was conducted across a lot of centers. A few colleagues were also involved in the trial. As per them, it was a negative symptoms. When we talked to them, who were part of those trials, they've been published. Questions are half-life is how much? So, why then OD dosing is being prescribed? Half-life is 6 hours, then ideally it can be a BD dosing, like vis-a-vis Qutican, or is it a sustained or extended release preparation? Is there
so like I talked about that mild hepatic or renal impairment, this can be given, but because extensive studies have not been done in case of hepatic complete impairment and that, so they have sustained release tablets are mostly given, sir. And
what preparation? This Cariprazine, is it being marketed or for consumption? Is it a sustained release preparation or it's a plain formulation? Because half
so
life is
it's
6
a
hours.
yes, sir.
Sustained release.
Yes, sir.
And the alpha 1B receptor, what is the importance of it? Because one of the slides you said that this
Yes.
is one of the hallmarks of this molecule.
Yes, sir.
So what is the benefit of alpha 1B receptors? Because alpha 1 is something which is a sympathetic kind of a
Yes,
an alpha receptor, which is being which controls the peripheral afterload. If it gets blocked, then there is a partial drop or something. So whether it's in blocking it or it is an agonist to that receptor, antagonist, and then how it will help in exceptional symptoms and akathisia. Because interestingly,
yes,
the most common side effects is akathisia. We are saying that we block this, it's an high affinity receptor and it helps
yes,
in akathisia. And pregnancy, you said that it is still is how much safer in pregnancy? Lactation, it is
yes, sir.
and the pregnancy.
सर ये steroid biosynthesis को कम करता है. So mostly the studies have been done in this, that reducing the biosynthesis of that. And one study was that it may cause withdrawal symptoms in neonates if being prescribed during the 3rd trimester.
Oral, is it teratogenic potential?
No,
Potency kitna hai?
no teratogenic
But again, the
propensity.
data is still very, very
Yes,
The dictum is your molecule shall not be used in specific general population, specific populations.
yes,
Because of the lack of data.
yes,
Because we might have now further more data. So older molecules, that is what guidelines say. Perinatal psychiatry says. Always go for older molecules because of more data you have regarding the safety in pregnancy and lactation. That's because you shared that one study, 400 patients, side effects.
Yes, sir.
Again, it's a very less data.
yes, sir.
Side effects, go to the side effects slide. The 5% one. So generally we see that the very less the proportion of side effects like sedation, weight gain and diarrhea. So we can use this molecule in these populations who come to us with complaints of sedation, comes to us with complaints of weight gain, because the proportion of side effect, how much the external validity of this limited data, we don't know, but we can choose these.
So this study was done in comparison with olanzapine and risperidone. So in comparison with that, all of the metabolic side effects and sedation was less.
This is a comparative study.
Yes, sir.
But this is the proportion of patients
Is
who
less.
had this side effect as per Cariprazine only.
Yes.
It is not a higher. But when you compare, then you will have those NNTs and number need to treat or comparative side effect profile. So that kind of a present. You have the data.
Sir, I've given it in my reference.
So one of the few things also you have to remember when you study this drugs or these these molecules being launched, interesting thing is when they'll compare with extrapyramidal side effects, so they'll compare with something like Q-tip. And when they'll compare with weight gain, they'll compare with something like haloperidol. Ulta. So that comparison में favorable है. तो आप extrapyramidal से extrapyramidal में haloperidol से they'll compare and weight gain में they'll compare with olanzapine as you said. So olanzapine का weight gain is maybe 10 kg, इसका weight gain 11 kg. So they'll say no, it is comparable or it is less. So that is something which we need to be little skeptical and critical about.
What time of the day we should give? 7 course sedation, but after they say night we should give what morning we should give.
So morning, so we can, yes, so OD dosage. Yes, sir.
OD can be given.
Yes, sir, but in the mornings.
In the mornings it is better.
Yeah.
In the night.
So it's nothing as such as written, but it was written OD dosage.
Any questions? Whenever a new molecule is launched, no, we cognitively make a map. Okay, this is closest to this molecule. So which is cariprazine is closest to which molecule? Which has already been there.
So Amy said right.
Because D2, D3 receptor
Yes.
stuff comes up there.
If PZA is taken presentation, I would say aripiprazole is also
Aripiprazole. D2 stabilizer. In my limited experience, I put it up one negative symptom, it is showing up. But one patient I started with positive symptoms because she left medication because of complaints of sedation and weight gain. So I started with her, then she deteriorated. 4 days only she came back that symptoms are increased. So maybe we can still look at it from negative symptom side, not a very robust positive symptom stabilizer kind of.
Also in adverse effect, we have to look at adverse that are commonly not. I think is something that I find stands out. Why should there be two tests? There should be, if there is no pharmacological explanation to this, which is more than sedation, 8.7%. What is the number of patients in the study? Do you have that data? How many patients?
402.
8.7 is large.
Yes.
Akathisia can do something. Akathisia, if drug induced akathisia happens, can it, and patient is having psychosis, can this do something to the patient? This side effect?
So he'll keep pacing up and down. That can cause restlessness.
If the patient who is having positive symptoms, we give it. Patient might say that my symptoms are in. Family students are also there. If you are interested, you can ask some questions.
Prescribing this medication to inpatient or outpatient, before we need to take or we need to see any blood investigation report. Like this medicine.
RFTs and LFTs. If the hepatic impairment is present and if the child PU score is more than 15, then we can't give it. If it is less than that, in 5 to 7 ranges we can. And again, the creatinine clearance, the blood urea nitrogen levels.
This is interesting because kidneys and renal safety भी नहीं है और hepatic safety भी उतना है. This alpride we used to say that it is hepatic safe. There's no data. It was relatively safe in pregnancy, lactation also. But only problem was prolactin increase. Any studies with prolactin increase there?
So I did study about it. It was a comparative study with again risperidone. So in comparison with that, sir. So has low risk of hypo, but then again in comparison with the, yes.
So that is what my whole point was.
Yes.
If you want to compare it with something which is less notorious. So you have to be more skeptical about this product issue. Dr. Sanjeevani, I think we have finished with the questions here.
Okay, sir. I think if there are no more questions, we can end the session. And it was a very good presentation, Dr. Ishani. Thank you.
Thank you, ma'am.
Okay, you can end the session now.
Thank you, ma'am.
Okay.